Ladies and gentlemen, a pleasure being with you today. Thank you for attending. The IFFS is delighted to bring to you a larger audience a series on male reproduction. This is not something that is routinely discussed, and rarely scientific programs on male fertility are produced on the web, particularly for a reproductive endocrinology and infertility audience. So without further ado, I would like to take you through firstly who I am. My name is Edgar Mocano. I'm a REI specialist in reproductive endocrinology and infertility, working in the Rotunda Hospital and the Royal College of Surgeons in Dublin, Ireland. I am, as it happens, the president of the IFFS. This is a series of 6 webinars, and it's presented by experts in the field of male infertility, being either andrologist. As you would have observed, this is a joint activity between the IFFS and the International Andrology Society. Each webinar will grant a certificate of attendance for all people that have been present. We will also grant a certificate of completion if you attend all 6 webinars. Among the people that are presenting to you will also be attending our Congress in Tokyo, but we will also look at sharing with you the possibility of participating in a research proposal workshop in Tokyo. So if you attend all 6 webinars and you are interested in research in male infertility, you could apply, and we will tell you if you've been successful and to be invited. All these webinars will be free to watch on our website. So just to mention, the next 2 webinars after today are in November and December. This will be 1 webinar every month for the next 5 months. And there will be sessions, 3 talks, and session of questions and answers. Without further delay, and I'd like to welcome our first speaker today. The first speaker today is Professor Ilpo Hutaniemi. Professor Hutaniemi has received his MD and PhD at the University of Helsinki, Finland. He did his postdoctoral training in USA at the University of San Francisco and NIH in Bethesda. And he has been also on sabbatical leave in Germany, USA, and Scotland. He was the professor and chairman of physiology at the University of Turku from 1986 to 2002, when he moved to London to take the chair in reproductive endocrinology at Imperial College until 2015. He has received numerous national and international honors, including Fellow of the Academy of Medical Sciences in UK, Doctor Honoris Causa of the Medical University Lodz, of University Szeged in Hungary and University of Tartu, Estonia. He had academic involvement also as the chief managing editor of Molecular Cell Endocrinology, also served on the editorial board of Endocrinology and Endocrine Reviews. His research interests are quite varied. He has a very high index score with Web of Science 91, Google Scholar 118, 750 peer-reviewed PubMed articles, and been cited 55,000 times. So without further ado, I'd like to ask Dr. Hutaniemi to talk to us on male reproduction, embryological development, and physiological functioning. Thank you.
Okay. Thank you very much, Edgar, for invitation first of all, and the kind introduction. Now I try to cope with Zoom and get share screen. Ooh.
While this is happening, I might just say to everybody that there'll be questions and answers after each presentation, and with that in mind, if you want to type your questions in the chat, please feel free. Also, you can ask them at the end. Thank you.
Okay, I think you can now see my screen. Is it okay?
Absolutely.
Okay, very good. So now we can start. So this is the title of my talk, and as a reproductive endocrinologist, I feel I have to start by showing the mantra of reproductive endocrinology, which is the hypothalamic pituitary gonadal axis. But I believe this is familiar to everyone. It just very briefly, it entails the secretion of GnRH from the hypothalamus, stimulation of gonadotrophin secretion from the pituitary gland, and then finally stimulation of gonadal function with LH and FSH, and the well-known positive and negative feedback loops to the hypothalamus. So this is all common knowledge. What may not be familiar to everyone is that above the GnRH neurons, a new level of secretion of regulation has been discovered, which is the kispectin neurons, another group of neurons in the hypothalamus where kispeptin plays a role in stimulating gonadotrophin releasing hormone secretion. And it is these are kispeptin neurons are the ones that respond to gonadal steroid negative and positive feedback. So this is a new level of in our knowledge about the HPG axis. So no more about that. And now let's go closer to my specific topic, which is about the early events of male reproductive endocrinology. So if you look at this red curve here, it shows the testosterone levels at different times of life from conception until old age. And it is quite a roller coaster. As you can see, there's a huge peak of testosterone in fetal life. And then the next peak in testosterone is during the first few months of postnatal life, followed by the quiescence before puberty, and then another activation, or we should say reactivation at puberty. And then testosterone production stays high for the rest of life, declining slightly in old age. So these are the different phases of periods of fetal testicular function. And now I only concentrate on the first two of them, on the fetal life and the second early peak, which is the neonatal testosterone production, which is also called mini-puberty. So sexual differentiation have multiple phases or levels. It starts with genetic determination, whether an individual is XY male or XX female. And if the individual is XY, his Y chromosome encodes a gene called SRY, which brings about the differentiation of the undifferentiated gonad into a testis. And in the absence of SRY, almost automatically, the gonad will become an ovary. And then very soon after testicular differentiation, the testis starts producing hormones. And very important of them is testosterone, but there are others as well. And now we can go to the next slide, which shows in further detail how fetal describes the endocrinology of fetal testicular function. So, as in the adult testis, the fetal testis have Leydig cells that produce testosterone. And in fetuses, Leydig cell testosterone production is stimulated instead of pituitary LH, it's stimulated by HCG, chorionic gonadotrophins, which is the superagonist of LH. And it stimulates in Leydig cells the production of testosterone, which then acts through the androgen receptor in the organs, internal genital organs, and brings about their differentiation. For instance, epididymis, vas deferens, and seminal vesicles. And then testosterone has to be converted by 5-alpha reductase activity to the more active androgen 5-alpha dihydrotestosterone, which again through androgen receptor stimulates the differentiation of the external genitals, like urogenital, urogenital sinus, and prostate and scrotum. And then a second hormone produced by Leydig cells is insulin-like 3, an insulin structurally close to insulin. And its role is, together with testosterone, to stimulate testicular descent from the abdominal cavity to the scrotum. One other detail about testosterone is actually fetal Leydig cells don't produce testosterone. They produce only androstenedione, which is then transported to Sertoli cells. Sertoli cells have the critical enzyme 17-beta-hydroxysteroid dehydrogenase type 3, and they convert androstenedione to testosterone. In this way, the fetal testis, testosterone production of the fetal testis is different from the adult. Okay, then we go to the other compartment, to the seminiferous tubuli, which in the fetus already contain Sertoli cells. Stimulated by FSH, they produce another hormone called anti-Müllerian hormone. Whether FSH is very important in fetal life is not quite sure, but postnatally, before puberty, the testis produces large amounts of AMH, and the stimulus is FSH. AMH in the male in the fetus binds to the Müllerian duct structures, which give rise in the female to fallopian tubes, uterus, and upper part of vagina. And this AMH hormone brings about involution of these structures in the male. And then we have the male sexual anatomical differentiation finished. But this is not all. So here are the genital differentiation with these structures, but then another very important sexual organ is the brain. And testosterone in fetal life brings about masculinization of certain brain structures and functions. So first we have the biological sex, and then later on, through effects of a sexually dimorphic brain function, we will have the so-called behavioral sex or gender, which can be divided into sexual orientation, whether the person is cis or trans, is homosexual, heterosexual in sexual orientation, and gender identity, whether the person considers himself according to his biological sex or in contrast to that. So the brain, in addition to the testes, is a very important endocrine organ. We can look at the different developmental windows of sexual differentiation with this slide. So at the time of the high peak of testosterone production by fetal testes, there is this, we could call this genital anatomical differentiation window, when the anatomical sex differentiation is induced. And then this is a bit hypothetical, but we can hypothesize that after this period, there is a period of brain sexual differentiation, which can be divided at least to sexual differentiation, sexual orientation window, and gender identity window. These windows are probably not identical because sometimes they don't overlap with the anatomical sex, as we will know. So here are a couple of facts about testosterone and sexual orientation, where the fetal period is very important. So we talk here now about gays, lesbians, bis, so in both heterosexuals and non-heterosexual LGBTQ individuals. So we know now that the amount and timing of testosterone exposure in utero is the critical determinant of human sexual orientation. This is still a theory, but the best available and supported by the best scientific evidence. And prenatal exposure to testosterone in particular is critical, because postnatal hormone manipulations, or whatever manipulations you try, conversion therapy and so on, don't do anything in the determination of sexual orientation. Sex hormone levels are similar in adult gay hetero men and adult lesbian hetero women. So postnatal sex hormone levels don't play a role in the determination of sexual orientation. And then there's clear evidence for this theory from numerous human observations and animal experiments. For instance, there are certain brain nuclei are different in size between men and women. One of them is the sexually dimorphic nucleus of the preoptic area. The other one is interstitial nucleus of the anterior hypothalamus, and anterior commissure also shows sex difference. Hetero males have these organs. These organs have, or structures have larger size in hetero males. Homosexuals of both sexes are somewhere in between, and hetero females have the smallest structures. Then a good example about prenatal androgen exposure. A good example about the effect of prenatal androgen exposure on sexual orientation is women with congenital adrenal hyperplasia. They are exposed to high levels of adrenal androgens in utero, and there's a high proportion of them with lesbian behavior, showing that testosterone does something also for the females on the female side. And then postnatal testosterone treatments of females or testosterone elimination in male rats reverses sexual orientation. This slide shows what happens in rats. If a genetic male is gonadectomized, the animals start showing non-masculine sexual behavior, lordosis, like the females do. And if a female rat is treated with testosterone or estrogen, it starts showing male-type sexual behavior. Something, probably similar mechanisms, not exactly in the same way, but we can be fairly certain the similar mechanisms function in humans. Here's one, again, theory how exposure to testosterone in utero determines whether an individual will have sexual attraction for men or for women. So these are the distribution curves for testosterone in female fetuses and in male fetuses. Obviously, they are much higher in males and inducing the male-type heterosexual behavior. And in the females, in the absence of this testosterone, these individuals are heterosexual women. But there is a certain level of overlap between these. And we can hypothesize that those women who are exposed to high levels of testosterone have higher frequency of homosexual behavior. And men exposed to lower levels of testosterone, again, has higher frequency of homosexual behavior. But obviously, this is not the only reason. It's just one example, one possible explanation. Okay, then let's go to the other early stage of testicular function, which is the neonatal period, or what we call mini-puberty. This is the time between about 1 to 6 months of age when gonadotrophin show an increased level after being very low before birth, and likewise testosterone shows an increase. The gonadotrophin levels go up also in females, but there's practically no gonadal steroidogenic response to these high levels in females. One clear finding in newborn boys is that during this period, their testis size increases. The next slide shows a kind of summary about the physiological effects of mini-puberty that are known at the moment. So it means the temporary activation of the hypothalamic pituitary gonadal axis between birth and about 6 months of age. And it starts due to the elimination of inhibitory action of placental steroids. As we know, the placental steroids are present in fetal circulation in very high levels, estrogens and progestin, and they keep gonadotrophin levels low in late gestation females. And when they are eliminated, gonadotrophin shoot up immediately as a sign of the mini-puberty. And the mini-puberty stops due to the onset of central inhibitory actions on the HPG axis, which are still incompletely known. But kisspeptin or cessation of kisspeptin secretion plays definitely a role here. At mini-puberty, we will find accelerated penile, testicular, and linear growth in baby boys. And concerning the testes, there is an increased number of immature Sertoli cells. This is an FSH effect. And it has consequences on sperm production in adult age, because the more Sertoli cells there are in the testis, the larger is the capacity of the testis to produce sperms. And then we might ask the question, why doesn't spermatogenesis start at mini-puberty? Gonadotrophins are up, testosterone is up. The reason is simply that Sertoli cells at this period don't express androgen receptor. So they are unresponsive to testosterone, and therefore testosterone, but spermatogenesis doesn't start too early. And then mini-puberty has been, these data are quite vague still, but there are some effects on gender-specific play behavior and language development of boys due to this early testosterone peak. And pediatric endocrinologists consider mini-puberty as a window of opportunity to diagnose congenital hypogonadal hypogonadism in micropenis and cryptorchidism, because in these cases, if hypogonadal hypogonadism is the diagnosis, mini-puberty, testosterone and gonadotrophin levels are very low. Okay, this was the essence of my talk, and then the final slide is a conclusion of this. So fetal testicular testosterone production starts at the end of the first trimester of pregnancy, and it brings about genital anatomic masculinization. Anti-Mullerian hormone is produced by Sertoli cells, and it causes involution of Mullerian ducts in male fetuses. Then the third fetal testicular hormone is insulin-like 3, which together with testosterone regulates the testicular descent to the scrotum at the end of pregnancy. And then what is very important is testosterone-dependent fetal brain masculinization, which plays a role in the determination of sexual orientation and gender identity. And finally, about mini-puberty, it is the assurance of sexual differentiation that it is brought to the completion after fetal life, and it plays a role in testicular growth and gender-associated behavior. And this is the end of my talk. Thank you very much for your attention.
Thank you very much, Dr. Hutaniemi. Very interesting basic science, but also immediate clinical consequences presented. I look forward to the questions and answers. Just to remind you, we do questions and answers after the last talk. And if you wish to place those questions in the questions and answers in the chat, please do. Our second speaker today is Dr. Michael Eisenberg. Dr. Michael Eisenberg is a board-certified in urology, but also a doctorate from Yale School of Medicine and bachelor degree from Rice University. He completed his internship and residency in urology at University of California, San Francisco, and also pursued a male reproductive medicine and microsurgery fellowship at Baylor College of Medicine in Houston, Texas. He serves as an associate editor of Fertility and Sterility and Andrology, and on the editorial boards of the Journal of Clinical Endocrinology and Metabolism, as well as the Journal of Assisted Reproduction and Genetics. He's a highly regarded international speaker, delivered invited lectures on many locations on the globe. His clinical and research interests seek to understand the implications of impaired sperm production on a man's health, as well as to develop methods to create sperm utilizing sperm cells. Without further ado, we're delighted to have Dr. Eisenberger talk on infertility as a proxy of male general health. Time to take note. Dr. Eisenberg.
All right, thank you for that kind introduction, Dr. Makano. It's certainly an honor to receive this invitation from the IFFS and share the screen with such esteemed speakers. As you heard, I'm going to talk about this link between a man's reproductive health and overall health. I've done research on this topic for over a decade now, and sometimes when we do this work, it's picked up by the lay press. And so men suffering from infertility read these studies or articles about the studies and reach out. So this is an example of that. This is a man I'd never met before, but he reached out to me, and you can see the subject line: "My wife thinks I might die because I cannot produce sperm. Hi, Dr. Eisenberg. My wife is worried I may be dying early because she's read several articles regarding men who cannot produce sperm have health issues." Now, another example through LinkedIn, which is a social network for professionals, regarding low sperm count linked to early death. The study has sent chills up my spine for several days, and I have questions which may calm my nerves. So we'll talk about these topics in a little more depth during the presentation here. And so we're going to talk about the etiology of the association, or the hypothesized etiologies, I should say, and then examine the evidence. So if we think about this link between infertility and health, and specifically those men worried about how infertility may be kind of a window into future health, we have to remember this is very much a reciprocal relationship. So current health is definitely associated with current fertility. And so why may this be? Well, there's been several hypotheses that may explain the link, and we'll talk about these all in turn. So first, we'll begin with genetic factors. So it's estimated about 10% of the male genome is devoted to reproduction. And given that there's only about 25,000 genes in the body, it makes sense that some genes may operate in more than one organ system. So here's a nice example of that. This is a study out of UCSF. It was performed about 20 years ago. And here they biopsied men at the time for IVF to try and find sperm. And so they've divided men into two groups. These are men with MA. This is maturation arrest, a form of spermatogenetic dysfunction leading to azoospermia. And then men with normal spermatogenesis. So these are men, for example, that had vasectomy and then had sperm retrieval for the purposes of sperm for ART. And then what they did is they took these biopsies and generated clones and just grew them and wanted to see how many of these clones develop mutations in their DNA. And what we can see here is that men with maturation arrests, it was very common for these clones to develop mutations. You can see up to 20% or even higher had these mutations. But for men with normal spermatogenesis, that was a very rare result. And so what this suggests is that there are some forms of spermatogenic failure where these cells, where men cannot faithfully replicate their DNA. And so you can certainly imagine, again, through checks and balances, that some of these men may not be able to produce sperm, which is what we see clinically. But you can also imagine these men may be set up for health problems, right? If they can't accurately replicate DNA, they may be at higher risk for cancer later in life. So that may be a link between reproductive health and overall health. There may also be hormonal factors. So we know that infertile men have lower testosterone levels than fertile men. We also know that testosterone is very important for health trajectory. So here's an example of that. This is from the European Prospective Investigation into Cancer. Here they had about 10,000 men, stratified them into baseline testosterone levels. And here the lower testosterone level has a lighter shade of gray. And what you can see here is that for men with lower testosterone levels, they had higher mortality rates. So again, potentially androgen status may provide a link between reproductive health and overall health. There may also be in utero factors, and I think we heard about this well from our prior talk. But we know that gestation affects the rest of our lives, and perturbations to the system may have a profound impact. So a corollary of this is the testicular dysgenesis syndrome, which pauses as different factors, whether they be endocrine, environmental related, or genetic factors lead to testicular dysgenesis. And if we look at the implications of this, we can see why this may link reproductive to overall health. So if you have decreased Leydig cell function, androgen insufficiency, you may get congenital malformations such as hypospadias, cryptorchidism. But you can also have disturbed Leydig or Sertoli cell function, impaired germ cell differentiation, which can then lead to reduced semen quality, so infertility, but also may lead to carcinoma in situ, so abnormal development of the germ cells, which can lead to testis cancer. So again, a direct link between reproductive and overall health. And then finally, what I call lifestyle or health factors. So if we think about how infertility impacts future health, we have to think about current health, right? Because the healthy I am today is going to impact how healthy I am tomorrow. So a nice example of that is, obesity. Obviously, we're in the era of a large obesity epidemic, and it's possible that GLP-1 analogs may reverse that. But that does have profound impacts on our reproductive health. So here's a meta-analysis from about 10 years ago where we're looking at body mass index on the x-axis and the odds of having a low sperm count on the y-axis. And you can see as body mass index increases, the odds of having a low sperm count decrease, again, linking health to fertility. But sort of a corollary or a very simple but profound question asked by Andrea Soloni and his colleagues in Milan about 10 years ago, are infertile men then less healthy than fertile men? So they looked at this in a prospective fashion. They recruited all men that came in to see them for fertility, compared it to a fertile group that they also recruited, and compared health by something called the Charleston Comorbidity Index. So I know many of us are familiar with it, but for those that not, it's basically a health metric. So every comorbidity is given a score. So a more severe comorbidity would have a higher score. Then you sum these all together to get a composite index. And so just like golf, a lower score is better. And so when we look at the summary results of that, if we look at fertile men in the second column there, men with a Charleston comorbidity score of 0, the second row, you can see about 90% of men have no major comorbidities. And you would expect that, right? If they're healthy, they're certainly thinking about future fertility. And that's what we see. Most of these men are very healthy, no major medical problems. But when we look at infertile men, the first column there, we see a much different story. Right here, only about 75% of men have no major comorbidities. So even at baseline, we see this difference in infertile men and fertile men, and that again may portend future health trajectories. So with that, then let's look more at what these men message about the future. And really our poster child for fertility and future health is cancer. And the classic example that's always discussed is testis cancer. And this was taught to us well by our Danish colleagues about 20 years ago, published in the British Medical Journal. So here what they did is they looked at 30,000 men that had a semen analysis when they were evaluated for fertility, and then linked it to their cancer registry and asked the simple question, is semen quality at the time of infertility evaluation associated with later testis cancer risk? So this is somewhat of a busy slide, but it's very important and kind of gets at the heart of this data. So we're looking at the different semen parameters, the different stratifications for that. So we'll just kind of go through the first one here. So concentration, 0 to 20 million sperm per milliliter. This would have been considered low at the time by World Health Organization standards. So there were 10,000 men in this group. They saw 33 cases of testis cancer. Based on population averages, they only expected 14. So here they saw twice as many. So the standardized incidence ratio is 2.3. So again, a doubling of risk here for these men with low sperm concentrations. If we look at men with normal sperm concentrations of 20 million sperm, there were 18,000 men in this group. They saw 42 cases of testis cancer, expected 37. So here the standardized incidence ratio is 1. So there's really no difference in risk when men have normal sperm concentrations. And we look at motility, we look at morphology, we see the same pattern. Men with lower semen quality have a higher risk of testis cancer. And this is fairly well established around the world at this point, that testis cancer and fertility are related. But how about other cancers, other male cancers like prostate? So this is another large registry study, this time from Sweden, again published in the British Medical Journal. And here the severity of male factor infertility was estimated based on the intensity of ART required for these men to become fathers. So all these men conceived, And you can see in purple, these men conceived with natural conception. The yellow represents men that conceive with IVF. And then pink represents men that conceive with ICSI. Again, sort of you can imagine the most severe form of male infertility would require ICSI. And what we can see is these men that develop prostate cancer tends to be highest with men with ICSI. The next highest would be IVF, and then the baseline rate would be natural conception. So here again, we're seeing this link between severity of male factor infertility and developing prostate cancer. Now, if we were going to think about using some of these sort of concepts that we've learned here about risk of cancer in these infertile men, it'd be helpful to figure out who to screen rather than screen everybody. And so we rationalize that potentially the most severe forms of male infertility, these men with azoospermia, with no sperm in the ejaculate, have the most severe form. And from our, earlier slides, we saw that some of these men have potentially mutations in DNA mismatch repair genes. And so these men really may be set up for highest risk. So we took our cohort of men, linked it to a cancer registry, and just divided these into men without azoospermia, so that's blue, and then men with azoospermia in red. And we can see here that men with azoospermia have a significantly higher risk of developing cancer in the years following infertility evaluation, about a threefold higher risk. So here we saw higher rates of testis cancer, prostate cancer, yes, but also saw intestinal cancers, cancers of the central nervous system, lymphoma, really melanoma, a host of different cancers here in this group, again suggesting that men with azoospermia here really may be at higher risk of developing cancers later in life. Now, obviously, there's other forms of morbidity and mortality for men in addition to oncologic ones. So let's look at some data on vascular metabolic disease as well. So here we're looking at ischemic heart disease. Again, we have our control groups. We have men that are diagnosed with male factor infertility, represented in blue, men that only went infertility testing in red, and then men that underwent a vasectomy. And vasectomy was sort of a convenient control group because these men generally have children. That's why they want a vasectomy. And here in the United States, based on access to care, sociodemographics, they tend to be very similar to infertile men. But what we can see here is that when we're looking at the risk of developing new ischemic heart disease, in the years following an infertility evaluation, the highest risk tends to be for men with male factor infertility. For diabetes, we see the same story. These men tend to have the highest risk of developing diabetes. And if you just look at the curves here, just 5 years after we see these men for infertility, about 5% of these men, 1 in 20 men, is going to develop new diabetes. And again, if we understand why this is happening, potentially we may be able to intervene, given all the complications that can arise through diabetes. So we kind of touched on this before, that maybe these men have some genetic causes. And, the American Congress on Medical Genetics, puts together potential mutations that, we potentially should screen individuals for because they are actionable. And so this is an international consortium where there are nearly 1,000 men with non-obstructive azoospermia. They were sequenced to see how many of these men possessed, these, actionable, known mutations in, different genetic syndromes. And about 3% of these men actually had, these mutations. And so we saw higher rates of familial cancer syndromes. Again, not surprising given some of the evidence I shared. But these men also had congenital heart disease and other cardiovascular conditions as well. Again, suggesting that there really may be a genetic link here, and there may be some screening practices that we could think about instituting to understand some of this and counsel our patients. Now, in the last few minutes, I want to talk about the ultimate outcome, what those men messaged about at the beginning, that would be mortality. So this has been studied a handful of times, so we'll go through some of the data. So the first is from Denmark. Again, sort of a similar study design we saw earlier, 43,000 men with semen data linked to the death registry, just to see if there was an association, again, between semen quality and mortality. And here we're looking at the percent motile spermatozoa on the x-axis, the risk of death on the y-axis. And you can see as sperm motility improves from left to right, the risk of death declines. And this exists for both men without children and with children. So again, not necessarily social factors that are leading this. There seems to be real biologic link. We see the same pattern with normal morphology or shape of the sperm. As sperm morphology improves, the risk of death declines. We looked at this in the United States as well. This is a busy slide, but we combined cohorts in Texas and California. I show this just to show these are reproductive age men in their 20s, 30s, and 40s, so very young. We didn't follow them for very long, just about 7 to 8 years. But again, just wanted to see if there's an association between semen quality and mortality. So here we're looking at a survival curve. The solid black line represents men with no semen abnormalities. The dotted line represents men with one semen abnormality. And you can see really no difference in mortality. But when we look at men with 2 or more semen abnormalities, the dashed line, we see a significant divergence in risk. And this persists even after we adjust for baseline health, like diabetes, heart disease, for example. And this 2.5-fold higher risk is what you'd see for men of this age group that smoke or have diabetes. And certainly we understand a lot more about the association of those conditions than we do why semen quality is associated with mortality. So just to summarize, infertility and health are very reciprocal, and that infertility may provide a window into later health, and we talked about many different conditions today. So with that, I want to thank you all, the invitation, for your attention, and I'll hand it back over to our session leader.
Eisenberger, thank you for a very revealing, thought-provoking presentation. I'm sure there'll be plenty of questions. Please type them in the chat. Our last speaker today is Dr. Giovanni Corona from Italy. He unfortunately has a family emergency, cannot be present in person, so he has forwarded the recording. He works as an endocrinologist and andrologist at the endocrinology unit of Maggiore Bologna Hospital in Bologna, Italy. He received an MD degree from University of Bologna and the board in endocrinology, as well as a Doctor of Philosophy degree at University of Florence. He has been top best European 30 researchers in 2015, co-authored more than 250 peer-reviewed manuscripts, and he is a lead in many editorial boards and many associations. Since 2018, he is the chair of the Scientific Committee of the European Society of Sexual Medicine. Without further ado, I would like to invite Professor Corona to talk on lifestyle modifications for men with infertility. What is the evidence? Can we have the slideshow, please? Thank you. I see there's a small technical delay, but thank you. I think we need to press the button play on this, please.
Relationship between the negative relationship between several wrong lifestyle factors.
Thank you.
Dear all, first of all, I'd like to thank the IFFS for giving us the possibility to share this series of webinars. And as Secretary General of the ISA, it is my pleasure and honor to be here, although not in a live way due to unscheduled reasons. So the possible relationship between the negative relationship between several wrong lifestyle factors, including smoking, alcohol, and drug abuse, and male fertility is well established. But today I'd like to share with you and to discuss with you a very conflicting and challenging topic, which is the possible relationship between obesity and male infertility. In this paper, including more than 200 subjects seeking medical care for couple infertility, we specifically evaluated the possible association between obesity and in particular between obesity and complicated obesity. So healthy obesity, obesity without associated morbidities, including dyslipidemia, type 2 diabetes or hypertension, as well as complicated obesity with the presence of at least one of these complications. And essentially, looking at the possible hormonal modification, we found that healthy obesity, so without comorbidities, was already associated with a reduction of total testosterone, a trend toward a reduction also calculated free testosterone without any modification of LH, suggesting at least a mixed hypogonadism related to obesity. Accordingly, when we use normal weight as the possible reference after adjusting for confounders, we found that either primary or secondary hypogonadism risk increased in healthy obesity as well as complicated obesity. But when we used healthy obesity as possible reference, only secondary hypogonadism increased the risk, meaning essentially that obesity is associated with an overall increased risk of hypogonadism, whereas complicated obesity increased the risk of secondary hypogonadism. And obviously, this is the first step for a possible association with impaired fertility. What is the impact of obesity on sperm parameters? Looking in this specific paper at the possible relationship between BMI and several conventional sperm parameters, essentially we did not find any association. So limited effects on sperm parameters. Moving to animal models and to a rabbit fed with high-fi diet for 12 weeks, essentially, as you can see, several conventional sperm parameters, including normal morphology, progressive motility, as well as total motility, were impaired in high-fi diet group. And this was confirmed in a larger study, including a larger number of rabbits, again, in association with progressive motility, sperm motility, as well as an association with an increased number of factors dealing with metabolic syndrome. So more convincing data coming from animal model. What about the results coming from meta-analysis in male subjects? This is one of the largest meta-analyses published so far in 2015. And as you can see, more than 100,000 people involved. Looking at the normal sperm count, however, overall no risk. In clinical symptomatic population, as well as in general population, an association a negative association with normal morphology just in a clinical population, not the case in the general population, with the progressive motility again just in clinical population, as well as an increased DNA fragmentation, obviously only in the general population. Moving to a more recently published meta-analysis, published in 2010, including 28 studies, seems, data coming from this meta-analysis seems to suggest that only severe obesity classes, such as obesity class 2, were associated with an impaired sperm concentration, sperm vitality, total motility, as well as total sperm count and normal morphology. So conflicting results on sperm parameters as a function of body mass index as derived from meta-analysis. How to better analyze this issue? In order to better analyze this issue, along with Daniele Santi, we decide to perform a new meta-analysis by selecting only those trials using WHO 2010 as the possible criteria for the analysis of sperm parameters. And during the following slides, I'd like to show you the data comparing normal weight versus obesity. And indeed, by using these specific strict criteria, we confirm that obesity was associated with a reduction of semen volume, with a reduction of total sperm count, which was tightly negatively associated with waist circumference. So the largest waist circumference, the higher the impairment of sperm parameters, so the lower total sperm count, the higher the difference between normal weight and obesity. Reduction of sperm concentration. Accordingly, the odds of reduced sperm concentration was up to 46% increased higher in subjects with obesity. Reduction of normal morphology, and again, waist circumference, the best predictor, reduction of total motility, and a reduction of progressive motility. And in line to what observed with the sperm count, the odds for reduced sperm progressive motility was up to 42% increased when compared to normal weight. So indeed, obesity is associated with severe impaired sperm count, and waist circumference is the main determinant. Any data on pregnancy rate or assisted reproductive techniques outcomes? These are the meta-analyses available since 2019, and as you can see, conflicting data when clinical pregnancy was detected, but at least two meta-analyses reported around 50% reduction rate of live birth in subjects with obesity when compared to those with normal body mass index. So male obesity can impair assisted reproductive technique outcomes. What about weight loss and fertility outcomes? This is one of the most important studies. As you can see, 8 weeks with very, very low calorie diet, and then people randomized to placebo, exercise plus placebo, liraglutide, and liraglutide plus exercise, up to 60 weeks. And as you can see, these are data coming from the first analysis, just intensive weight loss program, and there was an improvement of sperm concentration as well as sperm count, which was confirmed after 52 weeks, particularly to those people who were able to maintain the weight loss obtained. So weight loss can improve sperm parameters. But moving to bariatric surgery meta-analysis available since now, including 28 cohort study with more than 1,000 people, indeed, by collecting the available data, no positive outcomes related to several parameters, including volume, concentration, total motility, morphology, and progressive motility was not observed. So again, conflicting data coming from meta-analysis. So any better data? Along with Daniele Santi, we decide to perform another meta-analysis by applying very strict criteria. And indeed, in this meta-analysis published 2 months ago, last August, we were able to demonstrate that indeed weight loss was associated with an improvement of sperm concentration, which was tightly related to the delta, so the difference of body mass index between before and after weight loss. We were not able to find an association with an improvement of sperm number, but total sperm number. But indeed, we found an improvement of progressive motility, again tightly associated with body mass index, not association with total motility, but again, an improvement of normal morphology as well as DNA fragmentation. So by moving to my conclusion, essentially, we in these guidelines coming from the Italian Society of Androgenous Sexual Medicines, we recommended lifestyle changes. Our meta-analysis was not available at that time. In men with infertility to improve general health, I think that it's time to add and also to improve fertility outcomes. Finally, let me thank all the people involved in our study, particularly thank to Daniele Santi and to my mentor, Professor Maggi, and as General Secretary of the International Society of Andrology, I'd like to invite you to our next Congress, which will be held in Washington, D.C. in next March, where we will have a specific shared session with IFFS, and also as the president of the European Society for Sexual Medicines. For those who are interested, I'd like to emphasize this very interesting educational activity for EFUS, EFFM, ESSM Female Ultrasound School, which is educational activity specifically devoted for the improvement of the use of ultrasound for study of female sexual dysfunction. Finally, I'd like also to remind our National Congress on Sexual Dysfunction, Male and Female Sexual Dysfunction, which will be held in Vienna next February. Thank you for your attention.
Thank you, Professor Corona. Very interesting results from the recent meta-analysis, something that I have no doubt will raise some questions. I've seen some participants have already typed some questions. Without further ado, I would like maybe to start mentioning that at the bottom of the screen, there's a Q&A box. So if you want to ask a question, please type it in there so we can address it. One of the requests, more than a question, is could we have the reference and citations of the studies used in the talks? And I have no doubt that this can be easily organized through our office. So we will work on that and maybe place them on the website where the webinar will be hosted. But also we could share them on the emails once we have them all. There's one question about the testis blood barrier and antigenic mapping, but I couldn't understand the question. It said, what about the testis blood barrier? I would return it and saying, what about the testis blood barrier? What is the specific question that we want to ask? But while that person maybe sends the question, the relevant one is how to investigate azoospermia. So would either Professor Taniemi or Professor Eisenberger like to maybe say a few words on that, please? Thank you.
I can start with a few words. I mean, I think it's certainly, patients that we see a lot. I think what I would say is that there are some excellent clinical guidelines, offered both in Europe and in the USA. In the USA, the American Urologic Association, American Society of Reproductive Medicine have gave us some, very good guidance about the best management. For men with azoospermia, I think one of the first things that we want to do is differentiate whether there's spermatogenic dysfunction, so-called non-obstructive, or whether there's a blockage in the system or obstructive. So generally, you want to start, like all evaluations, with a history physical examination to see if we can understand, a little bit more about the medical history of that individual. We'll do some selective testing, including a hormone assessment, which will give us an idea whether there's a, again, an obstructive, non-obstructive process. In cases where there's non-obstructive, we're mandated also to check for a genetic cause, like a Y chromosome microdeletion or karyotype. You suspect there may be an obstructive component, for example, due to like congenital absence of the vas deferens, cystic fibrosis testing is done. And then, it really goes into management and counseling. Obviously, if there's an obstructive component, you can see about a possibility of maybe reconstruction or simply testicular sperm extraction. Non-obstructive, then generally want to counsel about options. Donor sperm adoption are certainly possibilities, but a microscopic testicular sperm extraction is also a very reasonable approach. And so counseling patients about the need for IVF, obviously fertility is a team sport. So you'd certainly want, the female partner to be evaluated at the same time you're doing these workups. Those are sort of my initial thoughts, but I would certainly point to EAU guidelines and, the American guidelines as well.
Thank you very much. Professor Taniemi, I like the presentation where you showed us the role that insulin-like receptor or enzyme might play in testicular descent. So would you be able to maybe hypothesize some research avenues? We all see a lot of the men in our infertility clinics with the sometimes unilateral, sometimes bilateral undescended testicles. And this is an area that I feel very little is known in terms of genetic linkage. So is there something that you could maybe inspire the audience in researching, or do you like to hypothesize what should we look at?
Well, testicular descent is not really my specialty, but of course I have followed the field to some extent. One thing, there's plenty of animal data about the effect of insulin type, insulin-like 3 on testicular descent. But the human data are very vague. There are a couple of cases, but we still don't know whether inactivating insulin 3 would cause testicular descent. So inhibit testicular descent. Testosterone, of course, plays an. So it's a combined effect, but there must be some other factors as well. And in most cases, the etiology of cryptorchidism is not known, and therefore I would urge anyone who is interested to get into the research. So there's plenty to do in understanding the pathophysiology of testicular descent.
Thank you for that. The second question is on how might population studies include more information on examining the relationship between infertility, men's health, and or sperm quality on overall health. So population studies to examine the relationship between infertility, men's health, and overall health. What should one include in this population data?
Yeah, thank you. That's a great question. I think, just bringing more attention to the subject, I think is really crucial and key. Usually when we track health of different populations, for example, here in the United States, we'll track, weight, we track blood pressure, but reproductive health, I think, is often not really thought about or tracked as well. For women, we're able to track, ovulatory cycles, for example, but, for men, we're really limited to semen quality, and that's often not done. So I think, having that knowledge and starting to gather data about it, but also when we are, doing surveillance, studies at a national level asking about reproduction, intent, difficulties, for example, I think that would be a good start. But I think just, looking at it as sort of a, just sort of part and parcel of an overall health. So, I've also kind of argued that maybe semen analysis should be another vital sign that should be routinely collected. And I think getting that information on men can be very important. And then as, men continue to age and may or may not develop health issues, we can see if there is that link, and it may give us some earlier information about it. But I think information and just kind of keeping it top of mind, I think, is really a good place to start. It's a great question.
Thank you. Along the same lines, but probably more related to Dr. Corona's presentation, is the question on the relevance of BMI as a method of assessment of obesity. And we know that it is a poor method to assess obesity. So the question goes, should the criteria for obesity not be updated to be more indicative of healthy versus unhealthy obesity, especially if we want to compare to fertility parameters? And I don't know if you want to say a few words about this or not. I think the risk, at least in the cardiology world, the risk has moved from BMI to abdominal circumference. So there's a clear risk in terms of an abdominal circumference over 102 centimeters in males. So I think the question is relevant and definitely the andrologist and the reproductive medicine specialist should probably come together to discuss what is the most relevant way to assess this risk in males with infertility. Any comments, Dr. Eisenberg or Putaniemi?
Well, I think you speak very well. I think we're continuing to gain information about it. I always remember that, it's not as popular in Europe, but here in the US, American football is very popular. And these men that play are really the peak of physical performance. They have body fats of, 1 or 2%. It's really incredible to see them. They're really, amazing specimens. But their BMIs are very high just because of how that is calculated. And I think it's a good point that it may not tell us everything we want. So I think updating that, and I think a lot of times cardiology is a little bit ahead of reproductive medicine in some of these measures. So I think we can certainly look to them and, maybe go back to some of our stuff as Dr. Corona had done to try and understand that a little bit better and counsel patients a little better.
Thank you. One of his slides from the andrology publication by Daniele Sante clearly show that the waist size or length or diameter or circumference, in fact, circumference on total sperm number is directly related. So the higher the waist, the worse the semen parameter. So as I said, these presentations will all be loaded up on the website, so one can look at each individual slide, and of course read the paper by Dr. Santi that was published this year in Andrology. I see there's one more question here, and it's the person that asked the initial one on the blood test as barrier, and it says antigenic mapping for primary spermatogonia. I'm not quite certain, not my immediate field of expertise. I don't know if Dr. Putaniemi has any answer to this.
Unfortunately, that's beyond my expertise. But about blood testis barrier, I would like to state something. Actually, it's a misnomer. It's not the blood testis barrier. It's a Sertoli cell barrier. It's a barrier tight junctions between adjacent Sertoli cells. It's not the blood testis barrier at all. Well, if that helps anything.
Okay, so thank you for that clarification. I hope that that brings some clarity to that particular aspect of care. I wanted to ask a question. What would you advise a male with infertility if you're to advise them only one thing once they're in your clinical practice? And I know it's very general because there might be many aspects, but what would you say to him if they are concerned? Think about what Dr. Eisenberg said. Men think of death and so on, and sometimes, many times, probably prompted by their female partners coming in with this publication saying, look what the literature says. So do you think there's something that we could just give them a bit of reassurance, a bit of encouragement, or how should we?
Yeah, well, I certainly don't want to be alarmist about any of this, right? These are men that are very vulnerable. We don't want to kick them when they're down, so to speak. So, I think ultimately we don't understand why this association exists. So it's hard to give any specific guidance about that. I don't send men to, geneticists, for example. But one thing I do talk about is just general association between health and fertility. And I think, giving sort of good health-related advice, I think certainly will help their overall health and maybe their reproductive health too. So we talk about good diet, exercise, maintaining good body weight. I think those are things that everybody can get behind. And again, we've seen some data that all that can be useful. So that's generally how I try and, start the conversation. If they don't have a primary care doctor, that can screen for diabetes, hyperlipidemia, hypertension, try and encourage them or facilitate a visit there as well. I think that a lot of times this is the first time they've ever had any health problems or really seen a doctor. So it can be an opportunity to sort of engage with the health community and get them set up. So that's the way that I've typically done it.
Thank you.
I have a small comment to Michael. How about lifestyle factors between men with children and without children? Is anything known about that? Could that play any role?
Yeah, so I guess I do give a much longer version of this talk, and so I think that I do talk about some of those factors too. And so I guess I put those into sort of social factors. So there's, things that necessarily are involved with reproduction. So having kids would be one potentially, and then having a partner, right? It's a team sport. So both of those actually are protective when you look at mortality. And so you certainly may change, some of your habits because you do have an idea of, kind of being there, people depending on you. But also just having that social support is important as well. And so I think all of that does factor into it. So having kids is definitely protective, even though it feels like our kids are killing us at times. They're probably not. And so I think those are things that do need to be thought about as well. We're doing a lot of these studies.
Thank you. I do have one question related to aromatase inhibitors. I'm going to combine two in one. What is the role of using them in infertile obese men? How long do you take it? And do you prefer anastrozole or letrozole? Now, letrozole, yes. So that's basically the question. Aromatase inhibitor use in obese men, how long to take it? Letrozole or anastrozole?
Yeah, so I think we do use it. I mean, generally, I'm guided by the ratio of testosterone to estradiol. Classically, it should probably be greater than 20 to 1. So if it's less than 10 to 1, I think that's, when a lot of us do think about prescribing it. A cycle of spermatogenesis is probably 2 to 3 months. So generally, if you're going to do it, I usually start men on it, check their hormone levels again in about 4 to 6 weeks to see if we have to adjust the dose at all based on, their hormonal response, and then check a semen analysis 3 to 6 months, somewhere in that window. So that's generally what we start with. I think it can be helpful. I think tends to be the more obese population. If you look at data, there's not a lot of reproductive data on it, but there are, some data that do support, certainly a hormonal response, but also some improvement in semen parameters as well. So I think in the right patient, it can be helpful, and it's certainly an option. Not FDA approved for that indication in the United States here. So it's an off-label use, but I think a lot of us certainly do offer that.
Thank you very much. There's a final question was from Cambodia, asking if you do not have genetic testing, how can you really care for the male? And I think maybe if you want to give 1 or 2 phrases here as an answer, I'd appreciate that.
Well, again, I think in select populations, we do offer it in a limited fashion. So for men with, sperm concentrations less than 5 million sperm per milliliter, we think about a karyotype assessment and a Y chromosome microdeletion. I think they'll help with counseling really, but the chances of any of those being positive, even for azoospermic men, is relatively rare, probably less than 5 to 10%. So I think if it's truly not available, I don't know that it's necessarily a huge disservice to men. I think it may, again, offer some, differences in terms of counseling. Obviously, a Y chromosome deletion we pass on to male offspring if you are able to find sperm. So important to know. And there are some rare deletions where sperm, procurement would be, nearly impossible, or again, very, very rarely reported in the literature. So it can guide that. And then obviously for karyotype as well, for translocations, or for aneuploidies like XXY, for example, you'd want to know that to sort of lower the risk of transmission. But if it's really not available, I think that, I think you can still offer, appropriate care. Or, again, I think if it's possible for patients to travel overseas, or there may be labs where you could, arrange international shipment. It's a relatively common test.
Thank you very much. It's been quite an exciting session here. Good questions. Thank you to all for asking questions and interacting with us today. In relation to the webinar series, I'd like to remind you the next webinar on male reproduction is on clinical assessment and diagnosis. So some of these questions asked tonight will be answered then. It's on the 12th of November, same time. There will be 3 talks: the clinical spectrum of male reproduction from normozoospermia to azoospermia, the optimal assessment of the male, and the Aphrodite classification. At the same time, So Dr. Corona promoting some activities. The IFFS is inviting all of you to consider presenting your research or attending for science at our World Congress in Tokyo in April 26 to 29, 2025. Registration is open and the abstract submission is still open. So please submit through the official portal. And then this is the submission deadline, October 21st, and the early bird registration, January 31st, 2025. With that, apart from saying see you in Tokyo, I'd like to thank you for attending. I'd like to say thank you so much for our three speakers for giving their precious time to these audiences and encourage the audiences to interact with us on email. There will be CME, not CME, but a certificate of attendance forwarded through the Zoom questionnaire. So please fill in your details and you'll receive the questionnaire. We look forward to seeing you at all the other male infertility webinars between the IFFS and the Andrology Society. Thank you to all. Have a good day or good evening. Thank you.
Thank you.